Hello, welcome to Lactation Education for Healthcare Providers. This module is entitled Evidence-Based Reasons for Providing Formula Supplementation. My name is Kara Rick. I am a graduate student at Arizona State University studying for my Doctor of Nursing Practice, otherwise known as DNP degree. I am a registered nurse. My interests are in breastfeeding medicine and improving care provided to mother-baby dyads. Myself, along with Marissa Honey-Jones, who is an international board-certified lactation consultant, will be presenting this module to you. Let's first go over our objectives for this presentation. Our objectives for this module are to accurately identify reasons to provide formula to the mother-baby dyad, specifically hypoglycemia in the infant weight loss, poor milk transfer, hyperbilirubinemia, delayed lactogenesis, and poor milk production. To describe the World Health Organization's International Code of Marketing of Breast Milk Substitutes and recognize proper office practices for display and distribution of formula, and to identify and state changes providers will make in their practice to promote breastfeeding as a normative practice and formula feeding as the exception. Finally, to identify the role of the International Board Certified Lactation Consultant and their role as a member of the interprofessional team in caring for and treating conditions of the breast. So let's get started. First, I'm going to talk about specific reasons that we may need to supplement with formula. There's another module in this series entitled Evidence-Based Research on Diagnosing and Treating Low Milk Supply that I would highly recommend you watch in conjunction with this module. Research tells us that about 85% of mothers are able to breastfeed without using any sort of formula supplementation. Trouble occurs when we start to separate mom and baby and introduce other tools to the breastfeeding relationship. In caring for the breastfeeding dyad, there are two main rules we want to be mindful of. First, feed the baby. And second, preserve the milk supply. Much of this module is going to focus on feeding the baby, but you as a provider need to have the tools to also help to preserve the milk supply. So let's start our discussion on medical conditions that require supplementation. I am going to be referencing two main documents as I discuss reasons for supplementation. The first document I'm going to reference is the World Health Organization and UNICEF document entitled Acceptable Medical Reasons for Use of Breast Milk Substitutes. This document was originally published in 1992 and recently updated in 2009. The information provided in this document is evidence-based off of the medical literature related to medical reasons to provide supplementation to babies. Experts from a variety of fields were utilized in creating this document. A copy of this document will be provided in the resource section of this module for you to access and read over, and also to download a copy of so that you can have as part of your practice. The second document I'm going to reference is the Academy of Breastfeeding Medicine's Protocol number 3, entitled Hospital Guidelines for the Use of Supplemental Feedings in the Healthy Term Breastfed Neonate. This document was revised in 2009. I want to make note about this document and also this lecture. We are discussing healthy, full-term babies in this discussion. There are additional protocols that discuss providing care for preterm infants, late preterm infants, as well as infants with a variety of other breastfeeding conditions. The Academy of Breastfeeding Medicine puts out multiple guidelines in regards to providing care for the mother-baby dyad. I would highly recommend you go to the Academy of Breastfeeding Medicine's protocol page and bookmark it. They update their protocols often and utilize the most recent evidence-based research when formulating their guidelines. A copy of this specific guideline is also included in the resource section of this module for you to download and keep for your needs and to use as part of your practice. So let's first talk about conditions where breastfeeding is completely contraindicated, meaning that the infant should not breastfeed at all. There are very, very few conditions where breastfeeding is contraindicated. Infant conditions that are contraindicated for breastfeeding are limited to genetic metabolic errors. Galactosemia is a disorder that affects how the body processes lactose. Only 1 in 3,000 infants are affected with this illness. Infants with this illness need to be given a special galactose-free formula. Another condition where breastfeeding is contraindicated with the infant is called maple syrup urine disease, also known as BCKD deficiency. In this condition, infants are unable to process certain amino acids properly. Maple syrup disease affects 1 in 185,000 infants worldwide. Infants with this condition need to be fed a special formula free of leucine, isoleucine, and valine. The last infant condition that is contraindicated for breastfeeding is phenylketonuria, otherwise known as PKU. In this condition, the infant is unable to break down phenylalanine, an essential amino acid. Phenylalanine can build up in the infant's body, leading to multiple disorders for the infant. PKU occurs in 1 in 10,000 infants in the United States. Infants with PKU need to be fed special phenylalanine-free formula. In some cases, breastfeeding can be possible with infants with PKU with very careful monitoring of mom and baby. Moms need to consume a special diet in this case, and baby's phenylalanine levels need to be monitored extremely closely so that we don't develop conditions that are associated with PKU. All of these illnesses that I have just discussed are screened for in the newborn screening tests that are given to infants once they are born at the hospital and followed up with at 2 weeks after baby is born. There are a few maternal conditions that are currently contraindicated for breastfeeding. The first is an HIV positive mother. And I want to note here that there is emerging research that this recommendation is changing. Currently, and especially in the United States, it is a standard of care for all infants born to HIV positive mothers to receive formula, as it is thought that HIV is transmitted through the breast milk. New recommendations from the World Health Organization based on evidence-based research suggest that infants born to HIV mothers actually benefit from exclusive breastfeeding. This is especially true in third world countries where access to clean water is not always possible and infant mortality is high. Infants and mothers need to be taking antiretroviral drugs throughout the period of breastfeeding. Infants should not receive any other food or milk other than breast milk to reduce their chances of contracting this disease if mom is HIV positive. The next maternal condition that is contraindicated for breastfeeding is cancer chemotherapy treatment. This is due to the fact that chemotherapeutic agents are able to enter the breast milk and cause great harm to the baby. This plays right into medications that may be harmful to baby. There's another module in this educational series that delves more in depth on medication management for breastfeeding mothers. I would highly recommend you watch this module. I will note here that there are excellent resources including books and also websites such as LactMed that can give you information on medication and compatibility with breastfeeding. Oftentimes, there are alternative medications to treat conditions that make breastfeeding possible. Please know your resources and make sure you are giving families the best evidence-based information when it comes to medication and breast milk. Now we are going to talk about conditions where supplementation may be necessary, but where breastfeeding is still entirely possible. In all of these conditions, infants should continue to receive breast milk from the breast, and supplementation should be used as a tool until exclusive breastfeeding can occur. Most all of these conditions that are listed here have some link with one another. So if you see a baby with one condition, chances are there are other conditions that are going on here that is creating either low milk supply, poor milk transfer, or whatnot. Conditions in the infant that may require supplementation are asymptomatic hypoglycemia that is documented by laboratory blood glucose measurement, not bedside screening methods, that is unresponsive to appropriate frequent breastfeeding. Symptomatic infants should be treated with intravenous glucose. The Academy of Breastfeeding Medicine has a hypoglycemia protocol number 1, that goes more into depth about this, and I would suggest that you download and review this protocol as part of your practice, especially if you're seeing mothers who have diabetes, infants that are born to mothers who have gestational diabetes, type 2 diabetes, whatnot, because this is where we start to see the asymptomatic hypoglycemia. I will provide a link to this protocol in the resource section as we talk this whole idea of treating hypoglycemia and asymptomatic hypoglycemia is a talk into its own. Clinical and laboratory evidence of significant dehydration, which is defined as 10% weight loss, high sodium, poor feeding, lethargy that is not improved after skilled assessment and proper management of breastfeeding, is another time when we need to start supplementing with additional either formula, supplementation, whatnot for baby. Before we get to this point, we should have employed the use of an international board-certified lactation consultant, otherwise known as IBCLC, to help troubleshoot feeding issues. So why is this baby experiencing dehydration? Chances are there's probably a milk transfer issue. Either mom is not able to make enough milk, or baby has a oral anatomy issue that is preventing it from latching appropriately at the breast to drain milk from the breast. Whatever the case might be, an international board certified lactation consultant can come in and diagnose these issues. Dehydration in the infant typically lends itself to weight loss. When we see weight loss of 8 to 10%, which is usually accompanied by maternal delayed lactogenesis 2, which I will talk about in a minute. Going back to the dehydration, we need to figure out the root cause of the dehydration and at the time feed the baby. So remember the two golden rules of breastfeeding. Feed the infant, preserve the milk supply. In this case, when we notice dehydration, and hopefully we haven't gotten to that point, certainly we need to supplement baby with something because we don't want to have negative outcomes for infant, but we also need to troubleshoot what is going on with mom's milk supply so that this dehydration is occurring. Furthermore, the next thing we talk about is delayed bowel movements or continued meconium stools on day 5. And in these cases, then there could be a genetic condition with baby. It could be related to dehydration. At this point, we need to do more of a medical workup to know why baby's having meconium stools at day 5 and why there are delayed bowel movements. And supplementation may be necessary, either because baby is not getting the proper fluids to move the bowels, or something else could be going on with baby that needs further evaluation. Insufficient intake despite an adequate milk supply is another point where the IBCLC should be brought in to help assess and provide care for the mother-baby dyad. There is another module within the educational series that addresses assessment of oral anatomy to try to understand the lack of milk transfer, entitled Evidence-Based Research on the Diagnosis and Treatment of Ankyloglossia, otherwise known as tongue tie. If baby is not transferring milk, and we know mom has a good milk supply, chances are baby has some oral anatomy issues that are preventing milk transfer. IBCLCs are fantastic at performing these assessments and making meaningful recommendations to help preserve the breastfeeding relationship. And when we talk about oral anatomy assessment and we talk about tongue ties, it could be necessary for baby to have a procedure where we clip the tongue tie, and this is further discussed in the other module. But know that having a meaningful and long-term breastfeeding relationship between mom and baby is entirely possible. So while you may need to provide supplementation for a few days, maybe a few weeks for this baby, breastfeeding should go back and resume to 100% exclusive breastfeeding in these instances. Last infant issue that may require supplementation is hyperbilirubinemia. There are two types of jaundice that we know about. The first type is neonatal jaundice, which is associated with starvation because breast milk intake is poor despite appropriate action. So this is what we've previously talked about. You may see dehydration, delayed stools, poor infant weight gain in these cases, and then another result is jaundice. In this case, you will most likely see the weight loss and dehydration. And the Academy of Breastfeeding Medicine has a jaundice protocol number 22, that I highly recommend that you download and look over, that I will also provide in the resource section of this module. Breast milk jaundice is the second type of jaundice that we talk about, and it is different from neonatal jaundice in that the infant is thriving. So infant is doing well, draining milk from the breast, everything's going great. There's limited, no weight loss, no signs of dehydration, stools are passing well. Breast milk jaundice typically appears 7 to 10 days after birth. With breast milk jaundice, breastfeeding should certainly continue here, but supplementation may be necessary because the supplementation prevents the billy from being ingested in the intestines to showing these signs of hyperbilirubinemia. The point where you do require supplementation is when bilirubin levels reach 20 milligrams per deciliter or higher in these breast milk jaundice cases. So this is where your detective stills come in. So why is this baby experiencing jaundice? We know with neonatal jaundice, we typically see that shortly after birth because baby's not able to transfer, mom's milk supply is not coming in. As I mentioned with breast milk jaundice, this is a case that we see 7 to 10 days after birth. Baby's gaining weight well, everything's going well with baby. And it's important to differentiate between these two types of jaundice and how we counsel parents and how we address these issues. In actuality, in all the cases that I've just talked about, breastfeeding should continue because remember rule number 2 of Golden Rule breastfeeding, preserve the milk supply. We want to feed the baby, of course. So even though we are supplementing, which is certainly going to be necessary because we want to have good outcomes for mom and for baby, we want to continue to stimulate the breast so that mom can continue to produce more breast milk. If baby is unable to transfer milk from the breast, pumping and hand expression should occur to preserve the milk supply until baby is able to obtain a proper latch and feed directly from the breast. I'm providing a video link in the resource section that talks about hand expression and how to perform hand expression to draw milk out of the breast. And this is a great instance where you would want to consider bringing an IBCLC in to meet with this mother-baby dyad so that we can do some troubleshooting. So IBCLCs are excellent at showing moms how to do breast massage, how to drain milk from the breast, how to use pumps appropriately. IBCLCs are also excellent detectives in trying to understand why there's an issue between mom and baby, there's not proper transfer of milk, and what's going on with the dyad, and helping them to troubleshoot so that we can move on and have an excellent breastfeeding relationship. So now I want to move on and talk about some maternal issues. We've just talked about many infant issues which require supplementation. And maternal issues that may warrant supplementation are delay in lactogenesis 2. I talk about the stages of lactogenesis in another module in this series entitled Evidence-Based Research on Diagnosing and Treating Low Milk Supply. If lactogenesis 2 is delayed, which lactogenesis 2 is considered to be the transition from the production of colostrum to copious milk supplied, and this does not occur by day 5, baby will need to be supplemented because baby is probably going to be experiencing dehydration and certainly weight loss because they're not getting any nutrition from mom, and so something needs to be done. Reasons that we know for delayed lactogenesis too include the biggest reason is retained placenta. In this case, lactogenesis will probably occur once we remove placental fragments. Sheehan syndrome is another result of delayed lactogenesis too, which is postpartum hemorrhaging followed by the absence of lactogenesis. And this is a case where mom either has emergency C-section, ruptured uterus, has lost a lot of blood, and her body is trying to recover to save mom. So if mom's body is in a state of shock, certainly she's not going to be able to produce breast milk for a baby. Certainly we need to be supplementing baby with formula, but once mom gets back to her normal homeostasis, we should be able to help mom to lactate and provide at least some breast milk for her baby. Primary glandular insufficiency is the last issue that we see, which results in delayed lactogenesis. And this typically occurs in less than 5% of women when we see primary lactation failure. This is caused by poor breast growth during pregnancy and minimal indication of lactogenesis, which is further discussed in the low milk supply module. And if you have a mother that actually has glandular insufficiency, this is something that probably should have been noted prenatally, because in these moms, you start to see what we talk about tubular breasts, which I'm showing on the next slide, and you see other anatomical issues that kind of tell us that breastfeeding might not go well or mom might not be able to produce breast milk. As I talk about in the low milk supply module, you should notice very specific breast changes throughout mom's pregnancy. And if you're not noticing these changes, we should be doing some sort of blood work, some sort of investigation to figure out why, so that we can possibly help preserve this breastfeeding relationship or even initiate some sort of breastfeeding between mom and baby. Breast pathology, which I talk about, is related to glandular insufficiency and or tubular breasts, and also prior breast implant surgery or even breast reduction surgery can result in low milk production. I'm going to talk about these two issues in a bit on the next slide. Intolerable pain during feedings generally indicates an oral anatomy issue with baby. As I mentioned about IBCLCs, is that they should be involved in the care of this dyad so that they can assess latch for baby, infant oral anatomy, infant suck skills, and mother's breast anatomy can be examined, and we can help resolve these issues as soon as possible. So moving on, the images you see on this slide give you an idea of what insufficient glandular tissue may look like. In this case, these are tubular breasts. And also the types of breast damage that we look for that may require supplementation. The image on the left of this slide gives you an example of insufficient glandular tissue. This image was taken from an article discussing plastic surgery options for patients that present this way. When a woman becomes pregnant, her breasts may change or they may not change. Insufficient glandular tissue is actually really rare. We see this in less than 1% of moms. And breasts should be examined prenatally to identify such issues as insufficient glandular tissue, and a breastfeeding care plan should be created. And I spend more time talking about breastfeeding care plan in the breastfeeding knowledge section, but if you know that there's going to be an issue with breastfeeding, or you know that mom may have had issues with breastfeeding in the past, creating a care plan just as we create a birth plan can be really beneficial to mom and baby in the breastfeeding relationship. It can be extremely helpful to counsel babies or to counsel families before baby is born so that there is a reasonable expectation of what breastfeeding will be like. If you look at the image I have posted here on the right in the slide, you will see where the fourth intercostal nerve is located in relation to the breast, as well as the importance of this nerve and how it affects nipple and areola. An incision in this area may indicate severed innervation of the nipple and areola and cause breastfeeding to be very difficult. You will want to examine the breast as it relates to any surgery involving the nipple, the areola, or any part of the breast. Oftentimes with breast reduction surgery, there has been an incision of the areolar margin. This can interfere with milk production. Again, this will usually be detected during a prenatal breast exam. A note of advice: just because a woman has breast damage, surgical alteration of the breast, or does not experience breast changes during pregnancy does not mean she cannot breastfeed her baby. She may certainly need supplementation, but breastfeeding is entirely possible between these mother-baby dyads. The majority of nutrition that baby receives can actually be from the breast, and only some supplementation may be needed. We know that the benefits of breast milk is huge, and research tells us that any amount of breast milk a baby receives is beneficial to that baby. So even if we have to supplement half of the time, if half of that baby's nutrition is coming from mother's milk, we are really providing that baby a better life, a better future, better wellness that we otherwise might not provide if we just jump straight to supplementation with formula and completely cut out breast milk. So there are a few, but not many, maternal illnesses that are contraindicated for breastfeeding. Dr. Ruth and Robert Lawrence have published a textbook that you can see here on the screen entitled Breastfeeding, A Guide for the Medical Profession, that is an excellent resource for providers to use. This book covers many issues related to breastfeeding. I would highly suggest purchasing this book to have as part of your practice and utilizing it. Appendix F of this book specifically covers precaution and breastfeeding recommendations for select maternal infections. Within this appendix is a list of organisms, syndromes, and conditions, and precautions that should be taken, breastfeeding acceptability, and compatibility of medication with breastfeeding. All material provided in this appendix is evidence-based with sound research backing the assessment. On the next slide, I will list a few ailments that are not compatible with breastfeeding at all, and that means mother has some sort of illness, organism, condition where she should not breastfeed her baby during the course of that illness, that condition. That does not entirely mean that we need to wean, but it does mean that while mom is ill, there needs to be a separation between mom and baby. Baby needs to receive food from another source. Mom can certainly pump and dump to preserve her milk supply, but we need to take some sort of action here so that we do not make baby ill and end up with a bigger issue than what we would want to expect. I want to stress the point here that the majority of illnesses that will afflict a mother are completely compatible with breastfeeding. There is so much research that has gone into breastfeeding medicine. As a practitioner, you should be familiar with the data and know what resources to utilize to give sound, evidence-based information to the patients that you see. And certainly in every area of medicine, emergency medicine, family medicine, adult medicine, women's health, pediatrics, you're going to see patients with a myriad of conditions. And certainly you can't memorize every single condition that may require mom to discontinue breastfeeding, wean, but know where your resources are, know where you can find information about medication, and utilize this material because it's quick as, looking at a website to give mom a peace of mind and help to preserve the breastfeeding relationship and help provide the care that that mother-baby dyad needs. So, going through Appendix F, I have listed the illnesses that are not compatible with breastfeeding on this slide. Looking at the list, you will note that the illnesses that are not compatible with breastfeeding are illnesses that are really quite rare. Diphtheria, and this only applies to skin lesions that are located on the breast. Ebola, rabies, Marburg virus, which is a type of hemorrhagic fever, human T-cell leukemia virus, Lassa fever, which is also a type of hemorrhagic fever, smallpox, and trichomonas, which is also known as sleeping sickness, which is transmitted by the bite of the tsetse fly, which is found in Africa, are the illnesses that if mom has these illnesses, she should not be breastfeeding her baby. The illnesses that are not compatible with breastfeeding, as you can see on this list here, are pretty few and far between. You can actually purchase just the Appendix F that I have gone through and listed illnesses here from the Breastfeeding Guide for Medical Professionals through Science Direct for a fee of $31.50. So if you don't want to go buy the entire Breastfeeding Guide for Medical Professionals by Drs. Ruth and Robert Lawrence, you can just purchase this appendix right here to utilize in your practice. But I think that you would, the book itself is actually only $100 through Amazon.com, and it provides you with so much other information about troubleshooting and treating breastfeeding conditions. And while this may not be the entire focus of your practice, having a basic knowledge is really important and can go a long way to helping the patients that you see. So now that we have a basic understanding of the reasons that we may need to supplement baby, I want to go over the various types of supplementation that we would use. Listed on this slide here are types of supplementation for infants. They are placed in the order of benefit from most desirable, which is the one that we certainly should use if available, to least desirable. Going back to the 2 golden rules of breastfeeding: feed the baby and protect the milk supply. If the mother is able to pump her milk, we are preserving the supply of milk because milk is being drained from the breast and baby is getting fed mother's milk, which is perfectly suited for that baby. If mother's milk is not available, either because mother is too ill to pump, she has one of those conditions that I mentioned before where she should not be around her baby, or mother's milk has not come in, or mother's having very difficult time removing milk from her breast, milk that is from a milk bank is the next best option. There are several milk banks throughout the United States. I'm giving this presentation here in Phoenix, Arizona. The closest milk banks to us are in California, and there's another in Colorado. To locate a milk bank near you, you can visit the Human Milk Banking Association of North America. And I will provide the link to this website in the resource section so that wherever you are in the United States, you can go and find where the most closest milk bank location is. So the next best option after donor milk, if we're not able to get milk straight from mom, the next best option is donor milk. If you are a patient and are seeking and or receiving donor milk, I would caution you to know what the source of the milk is. There are a few online groups that facilitate milk sharing, especially here in Phoenix, and they're called Human Milk for Human and Eats on Feeds. I would strongly caution against families paying for breast milk and buying breast milk over the internet, especially if you do not know or you have not met the donor in person. There is some current research that suggests that breast milk bought through the internet is not actually breast milk and can be harmful to infants. Human Milk for Human Babies and Eats on Feet are both milk sharing sites. They actually have Facebook pages that you go on to and donors discuss and choose to meet up with each other. And both of these organizations, milk is not sold or bartered for. Instead, milk is offered free of charge. The next option, if no breast milk is available at all, so we do not have mother's milk, milk bank is not an appropriate use, or we cannot get milk bank, or donor milk is not available, we look to ready-to-feed formula. Ready-to-feed formula is prepared, packaged, and placed on the shelf. There is no mixing, measuring, or combining of formula. This type of formula is the most safe and generally free of contamination that could make a sick baby already even more ill. This type of formula is typically used in neonatal intensive care units, as both liquid concentrated and powdered formula have potential for contamination either from water or from the processing of the powder. The next option, if we do not have ready-to-feed formula that should be considered, is liquid concentrate. This is a concentrated formula you buy from the store and then you add your own water to it. This product is pre-mixed and put in the package. Contamination has the possibility to occur when we purchase the concentrated formula because we are introducing water. And so certainly in the United States, we typically don't have these issues unless you're talking about families that have well water. And then we have, the research has noticed some issues with well water. But certainly third world countries have contaminants in their water that make babies very, very, very sick. So that's why liquid concentration is low on the list. And the bottom of the list is powdered formula. And there are a couple reasons why this is at the bottom. One is because of the possibility of bacterial contaminants. Powdered formula is not sterile, and it may contain bacteria that can cause serious illness in an infant. As you might recall, there have been many recalls of powdered formula. The proper way to prepare powdered formula, and this is manufacturer recommendation, is this. You want to bring water to a boil, add the proper amount of water to a clean bottle that ideally has been sterilized. Water can be cool, but should be no cooler than 70 degrees Celsius after it's been boiled. And then we add the proper amount of formula to the water. Mix the water and the powdered formula together and allow it to cool to lukewarm to feed the infant. It is really important that you counsel your patients on this information about how to properly prepare powdered formula, especially if an infant is really young, because we know that when an infant comes and when an infant is born, they have no immune system at all. And so that's why breastfeeding is best, is because in mother's breast there are antibodies that are passed on to baby to help them to start to formulate this immune system. When we start to go straight to formula, there are not antibodies in formula, and so the infant who already has an immature immune system, if this formula is contaminated, will make this baby really, really sick because they have nothing to fight off this illness. They have nothing at all, and that's where we end up with issue. If you have a baby who is already ill and you're going to give them powdered formula that is potentially contaminated, you're only going to exacerbate this issue, and it could lead to a very, very negative outcome. So really knowing the hierarchy of providing supplementation to babies is really important to know, and knowing that breast milk is #1 choice. Then we know that prepackaged formula, then liquid concentrate, and then powdered formula are the choices that we have, and make the best decisions and counsel families with this information. It's important and necessary to cover all of these issues with parents and help to provide them with the best solution that will help their family and help their situation. And certainly there are going to be multiple situations, which some of them I probably don't even cover here, but having a background knowledge and knowing your resources is extremely beneficial. So now I want to discuss delivery methods for supplementation. So we know reasons why we need to supplement. We've just talked about the different types of supplementation that are available, and now we want to talk about how we're actually going to supplement the baby. And this information is just as important as knowing the whys of supplementation and the whats of supplementation, because this can make a really big difference in being able to come back and preserve this breastfeeding relationship if that is possible. So certainly we probably have all heard of bottle feeding. I mean, that's what we are bombarded with in our culture, on the news, on billboards, advertisements in the mail. And there's a great deal of evidence that suggests that the way we introduce supplemental feeding can have an impact on the breastfeeding relationship. So I'm going to spend some time here talking about the science and research surrounding the various methods for supplementing the baby. The type of supplementation you choose is equally as important as the method you offer to supplement. So the top 2 choices really for providing supplemental feeding are a cup or a supplemental nursing device. Nipples, teats, and bottles really should be avoided here unless absolutely necessary. First thing I'm going to talk about here is actually the cup, which you see here, and you actually see on the screen a cup feeding occurring. In addition to discussing cup feeding here, I will include a cup feeding video taken from YouTube so that you can kind of see how cup feeding works in an infant. And if you haven't seen this before, it's actually kind of pretty cool to see how a young infant actually can just draw supplementation out of a cup, and also to give you an idea that it works. Like this is what's used around the world, because bottles, nipples are expensive. And so when we start talking about supplementation in third world countries, a cup is cheap. Bottle, nipple, not so cheap. So kind of having this background knowledge in your head can actually be beneficial to you, and to share with families. So how do you feed with a cup? You want to start with a small cup, shot glass size. Certainly don't use a shot glass because it's not very malleable. That holds 1 to 2 ounces of either human milk or formula. The cups that are made of flexible plastic, like medicine cups, that you can bend into a spout shape. You can use a small cup that you already have at home, or they actually sell cups on the market that are actually designed specifically for infant feeding. You're going to fill the cup about halfway full with the supplement, whether that be the breast milk or the formula. And you'll want to have several cups there so that you don't have to interrupt the rhythm of the feeding to stop and refill the cup. So with baby, you're going to tuck a cloth or a diaper underneath baby's chin to absorb anything that drips out. Or an absorbent bib is fine. And you'll possibly want to swaddle baby in a receiving blanket, possibly not, because hands kind of get in the way, because one of the signs of hunger, the cues of hunger, is hands at the baby's mouth. And so if you're trying to put a cup to baby's mouth and baby's hands are up there, baby's reaction or reflexes are a little immature, so it can be helpful to swaddle baby. So you're going to hold the baby in your lap, or certainly position the baby in an upright position. You're going to hold the cup to the baby's lip, and you're going to gently tilt it until the milk reaches his lips. You want to be very patient with this and allow baby to lap up the milk or drain in the milk and swallow at its own pace. So this is not just pouring the milk in the baby's mouth and so baby's guzzling it down, because this ultimately results in sputtering and choking. You kind of let baby pace in and let him decide when he's finished. And so one of the cool things with the cup feeding is that because babies know about suck, because with breastfeeding it's suck, swallow, breathe, and we have peristalsis, baby's still able to suck and draw in milk from the cup, and they're really able to get all the nutrition that they need. So when do we use a cup feeding? We use cups when baby has not yet learned how to latch at the breast, or there's actually a latch issue. When baby is having problems with nipple confusion, when baby is likely to need supplementation for a short period of time, or when an older baby flatly refuses the bottle. And so cup feedings are really good for if baby is able to go to breast and able to drain out the breast and mom may have low milk supply, cup feeding can be very beneficial to take the cup and then supplement after baby is at the breast, so there is no confusion between feeding at the breast and cup feeding. So moving on, another option that we're going to talk about here is finger feeding, and I will also provide a video of this in the resource section so you can kind of see what finger feeding looks like. The video in the resource section is actually a baby that just breastfed from mom and is having trouble in the hospital, and dad is actually doing the finger feeding. So finger feeding uses a nursing supplementer or sometimes a syringe to deliver milk to the baby while it sucks on an adult finger. The supplementer tubing is taped to the adult finger, and the finger is gently inserted into baby's mouth, and you can either use a feeding syringe or finger feeding, and we gently insert the tip into the baby's mouth while the baby is sucking on the finger. And we have the plunger, and we're depressing on the plunger to deliver milk to the baby while baby sucks, and pauses as the baby pauses. And the nice thing about this is you can use mom's milk, you can certainly use formula or whatnot to feed the baby, and this helps baby to learn how to suck correctly. So this is almost considered like suck swallow training. So in an infant that is preterm, late preterm, that may not actually have the coordination correctly, this can be really beneficial. So finger feedings typically are used when baby is not able to latch at the breast, and when we are teaching baby to suck correctly. And in these cases, both when we use the cup and both finger feeding, and even the next issues I'm talking about, please employ the use of IBCLC, lactation consultant, because they have so much knowledge about this. And certainly you may not be the one doing this, but you should have a base knowledge of what's going on here. So if you have a patient that comes into clinic and says, I'm doing cup feedings, I'm supplementing with a syringe, you know what's going on. And these videos that I provide from YouTube in the resource section really can just give you kind of a basic idea of what it looks like, what mom and baby is doing. Next thing I want to talk about is the supplemental nursing system, which is also known as an SNS. And this can be used with mom for two purposes. So the first purpose that we use an SNS is when we have two purposes, is to provide infant nutrition, and the second is to help stimulate milk supply. So going back to the golden rules of breastfeeding that I will mention again and again, feed the baby, preserve the milk supply. SNS does both of these. You're feeding the baby through the SNS and you're preserving the milk supply. This device allows baby to receive supplement or formula or expressed human milk while sucking at the breast. A container for the milk, which is either a plastic bag, a plastic bottle, hangs down from a cord around the mother's neck, as you see in the image here. There are narrow silicone tubes that run from the container to the tip of the mother's nipple and is secured with tape. When baby latches onto the breast, he is also taking this tubing into his mouth, and when he sucks, he gets the supplementation from the SNS along with the supplementation from mom's breast. The sucking helps to stimulate mom's milk supply. So if mom has no milk supply, and in the case maybe like adoptive baby or mom is trying to relactate, baby's getting nutrition from the SNS and then trying to tell mom's body to start producing more milk. And then the supplement that he gets is a reward for baby sucking properly, and baby then, teaching sucking at the breast, wanting to come back to the breast, knowing that the baby's going to get the nutrients he needs, and also allowing for mommy-baby bonding when you are using an SNS. The nursing supplementer is used by mothers who are nursing adopted babies, as well as by mothers who are relactating, which is reestablishing a milk supply either after premature weaning. The illnesses that I mentioned when mom and baby may have to be separated. Nursing supplementers are also used with preemies and babies with various kinds of sucking problems that prevent them from getting milk directly from the breast. And to use a supplementer, the baby must be willing to latch to the breast. So, no oral anatomy issues, no sucking issues. And if we're having oral anatomy issues, suck issues, then we go back to the cup or we go back to the finger feeding so the baby can get the nutrition that he needs. And mom can stimulate breast tube pumping, hand expression, and whatnot until baby can get the coordinated suck, swallow, breathe pattern. Baby can get oral anatomy corrected or whatnot. So when do we choose to use a supplementer in our practice? When baby is able to latch onto the breast but cannot get sufficient nourishment from breastfeeding alone, when training a baby to suck correctly at the breast, and this is a case where we'd want to get a lactation consultant. All of these are cases where we want to get a lactation consultant involved. When the need for supplementation is likely to continue for several weeks, so going back to preserving the milk supply. And it may take, with these supplemental nursing systems, it can take a while to become comfortable with using them. It's not entirely comfortable for mom, and it can be a little bit awkward. And so using a cup feeding in the interim, syringe feeding in the interim can be short-term while we kind of get mom and baby acclimated to this SNS. When you wish to use to supplement baby, the SNS is also good when we want to supplement baby at the breast and avoid the time and effort required to give baby additional feedings after nursing sessions. So with the cup and the syringe feeding, try and feed baby first at breast because we're trying to preserve milk supply, and then we do this afterwards to continue to provide nutrition to baby. And then as we talked about, relactating or nursing the adopted baby. When we consider any supplemental option in delivery, please talk with an IBCLC before using any device. The lactation consultant can help you decide what the best options are for the situation, and she'll be able to help resolve breastfeeding problems that have really created the need for these supplementers. Last thing that I want to touch on in terms of supplementation and type is bottle feeding. And so I mentioned in the beginning that the bottle feeding is kind of the least desirable option, and if we do have to use a bottle, then we want to use paced bottle feeding, and you see an image of paced bottle feeding going here on the slide. As I mentioned before, the bottle nipple tea, this is a last resort. And so this is a case where either families may not be willing to use a cup, may not be willing to do starch feeding, may not be able to use an SNS for whatever reason, but know this information, have it, and counsel your families accordingly. Research shows us that feeding babies anything by bottle can have an effect on their ability to regulate their uptake. One theory suggests that the inability of self-regulation intake is related to a higher risk of overweight and obesity, and this is why we use this paced bottle feeding, because if you think about babies flat on their back, we have the bottle going in, babies are like, go, 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 it's going to be running down baby's throat, whereas baby is upright, introducing the bottle. Baby, it's more like breastfeeding. Baby's at the breast, baby has to draw milk out, and so it makes it so that baby has to work for it, but also it helps baby to know when baby's satiated, so baby like, I'm done eating. Whereas when baby's on its back, and you think about you eating too, if you just keep eating, you don't always get that message right away when we're full, and so a lot of counseling we do with our patients is to eat meals slowly, to sit down, enjoy the food, taste the food. Feeding babies the same way. So if we are going to use a bottle to feed, you will want to discuss paced bottle feeding with families. In addition to what I'm discussing here, there is a video resource in the section to give you an idea of what paced bottle feeding looks like. So just so you know, beyond me talking about it here and you looking up here in the corner and trying to see what I'm doing, paced bottle feeding allows for baby to have control over his or her intake of breast milk by responding to their cues, and also to prevent post-feeding fussiness by reducing overfeeding, because just like with adults, when you have an overfull tummy, you don't feel very good. A baby with an overfilled tummy does not feel very good. And since much of paced bottle feeding also mimics feeding at the breast, it can also support the breastfeeding relationship and help babies transition back and forth from breast to bottle. Babies may be less likely to get accustomed to the fast flow of the bottle and reject the breast when we are using paced bottle feeding. So how does it work? We are going to be feeding baby based on cues. This is not scheduled feeding. Just as with breastfeeding, we don't schedule when baby says they're hungry, then we want to introduce food or supplementation. We want to hold the baby so that they're in an upright position, almost a sitting position, and avoid feeding by bottle when the baby is reclined, because this reduces the controlled milk flow. We want to hold the bottle in a horizontal position, tilted only enough to keep milk in the bottle and the nipple. We don't want to force the nipple in the baby's mouth. Rather, we want to elicit the rooting reflex by taking the nipple, touching at the nose, and drawing downward to teach baby to open mouth wide. And encourage baby to latch onto the nipple just as we would encourage them to latch on the breast. We want to ensure the baby's mouth placement on the nipple is good. We want to allow baby to set their own pace for feeding and aim for the same length of time as the feeding at the breast might take. So typically a good feeding at the breast, 20-30 minutes. As baby gets older, these times vary. But certainly a feeding should not be done in 5 minutes, because then you either overfed the baby, baby's feeding too fast. Encourage baby to pause frequently during feedings, resting the nipple on the baby's lips, or take a break and burp him. Baby will start sucking again when he's ready. Switch sides during the feeding to mimic feeding at the breast, and even out eye stimulation. So, when we're breastfeeding, we're looking down at our babies soothingly, lovingly. Same thing with paced bottle feeding, holding baby, feeding baby, looking down at baby lovingly, just as we would at the breast. Never try to force a baby to take more than what she wants or to finish the bottle. If you're worried about squandering precious breast milk, if you're putting breast milk in these bottles, which we totally understand, use smaller amounts, maybe 2 ounces at a time, and providing more as baby needs. International Board Certified Lactation Consultants, or IBCLCs, are extremely well versed in these various types of supplementation and modes of delivery. It is really important for you to have a base knowledge of the modes and types of supplementation so that you can have a meaningful dialogue with your patients and really help to troubleshoot and really help preserve breastfeeding relationships. Employing the use of an IBCLC within your practice or having relationships with IBCLCs within the community can be extremely beneficial to both you and your patient population. So now that I've spent some time talking about reasons for supplementation, types of supplementation and modes of supplementation, I want to transition this talk into the International Code of Marketing of Breast Milk Substitutes, which is a code put out by the World Health Organization. I am providing a copy of the International Code of Breast Milk Substitutes in the resource section of this module so that you might have a look at this important document to further understand its implications and importance within the medical community. The International Code of Marketing of Breast Milk Substitutes was adopted by the World Health Organization on May 21st, 1981. At this time, there were 118 votes that voted for it, 1 vote against it, and 3 abstentions. The one sole vote against the International Code of Marketing of Breast Milk Substitutes came from the United States. The United States argued that the regulation of marketing of baby food interfered with free enterprise, though none of the other nations that were involved in this vote or other Western democracies shared this view, and nor did many Americans, and even many Americans now do not share this view. The International Code of Marketing of Breast Milk Substitutes took into account the importance of an adequate basis on which women can have a true and objective choice in determining how to feed their babies. The code also emphasized the need for education and information about infant and young child feeding and for the establishment of measures at a government level to protect women against misinformation. The International Code also recognizes that inappropriate feeding practices leads to infant malnutrition, morbidity, and mortality in all countries, that improper practice of marketing of breast milk substitutes and related products can contribute to this major public health problem. And so, why am I talking about this if the United States hasn't adopted it? And the reason is because you make a difference. You make a difference with your patients. You make a difference among your colleagues. And so if you're going to take a stance against marketing a formula, providing formula in your office, then you're going a long way to make a difference, because the research tells us, and there's a lot of research out here that tells us this, that families make decisions based on their perception of their primary care providers. So if you are promoting and talking about breastfeeding within your practice, chances are your patients are going to choose breastfeeding. And if you have a patient that is on the fence or really even leaning towards formula feeding and you're pro-breastfeeding, research tells us that they're more likely than to initiate and start breastfeeding than if you either had no opinion at all or you were promoting formula within your office. And the research also tells us that if you're promoting formula within your office, then this also leads to reduced time in breastfeeding relationships. So what is the aim of the WHO Code? The aim of the WHO Code is to protect and promote breastfeeding by ensuring appropriate marketing and distribution of breast milk substitutes. And the scope of the WHO Code applies to breast milk substitutes, i.e. formula, in bottles and teats, when marketed or otherwise represented as partial or total replacement for breast milk. It also applies to the advertising of bottles and teats, as I just mentioned. Essentially, the WHO Code advises that there should be no advertising of formula to the public, not on television, not on radio, not on billboards, not in the mail. No free samples to mothers, their families, or healthcare workers should be given, meaning that we should not be distributing in the hospital, we should not be sending these samples out in the mail, we should not be giving them out in doctor's offices. No promotion of products, no product displays, posters, distribution of promotional material in any capacity, even within a doctor's offices, a store, or out in public. No use of mothercraft, nurses, or similar company-paid personnel, meaning that formula companies should not pay employees, specifically healthcare workers, to promote or discuss the benefits of their product. No gifts or samples to health workers should be provided. Product information must be factual and scientific. And no free or low-cost supplies of breast milk substitutes of any part should be available within the healthcare system. If we think about the WHO code and we think about our current healthcare system in the United States, we recognize that the U.S. healthcare system as a whole does not embrace or recognize any part of the WHO code. Certainly, we are starting to make strides within the hospital to not offer any sort of sample or gift packs to mothers, and that this has resulted in a similar push for hospitals to receive baby-friendly hospital status. So as part of baby-friendly hospital status, hospitals cannot offer formula, the gift bags, the coupons to mothers after they deliver a baby. The only time formula is used is when it is medically indicated for the issues that I discussed previously in this module. The reason that I'm sharing all this with you is so that you can make ethical decisions in regard to your practice and consider the message that you are sending to families. So within your practice, if you have a formula clock on the wall, you're using a formula pen,